From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the Web and Social Media Editor. Today, talking about team dynamics in hip and knee arthroplasty and operative efficiency. My guests today are Mr. Henry Cousins and Dr. Derek Amanatullah.
Thanks very much.
Hi.
And they are both coming from Stanford University. I really appreciate you all taking the time to talk with us. I have a habit of starting out our author interviews by asking how you got interested in your research question. So can you tell me more about how you developed your interest, leading you to pursue research on effective team dynamics?
So this is Derek Amanatullah. For me, this really was born in 2017. I was chosen as a Stanford faculty biodesign fellow. And actually, I thought, like most surgeons probably, that my team was the people operating with me. And my mind kind of expanded when I studied using computer vision, studied laparotomy sponges and needle counting by the operative staff, by the circulating nurse and scrub tech. It really led me to understand that there were more members of my team that contributed to how my operating room ran beyond the actual execution of the procedure. And we published some data in the Bone and Joint Journal about my team. But there were observations from that really led us to think about how entire surgical teams performed and how they were more efficient and how they communicated across multiple surgeons. And that really led to the genesis of the study.
Thank you, Dr. Amanatullah. I think anyone who works in a team knows that there are lots of these latent dynamics of team performance having to do with the nuances of communicating all of this complicated information quickly among many people that are really important to overall productivity. And surgical teams are a great example of this. And there's a long history of using team-oriented operating principles, checklists to standardize communication rules to improve operating room performance. And I'm personally fascinated by this idea that there might be widespread, non-medical, and most importantly, modifiable aspects of healthcare delivery that measurably affect patient outcomes. And I think if we can understand these elements, these human aspects of practice that substantially affect the patient experience, even when we're not actively thinking about them, then we can really offer clinicians a powerful tool to improve their patients' outcomes. The challenge for us is that these factors are hard to measure just by their nature. And so our question was, how can we begin to quantify these subtle non-medical factors that shape operating room performance? And as Dr. Amanatullah mentioned, we looked at this originally in a smaller pilot study, and we wanted to see in this case if our earlier results might generalize to other surgeons. And so in this study, we've expanded our pool of cases by an order of magnitude, and we think gotten much more generalizable results.
So you mentioned the issue of measurement of the different factors that can influence the effectiveness of how things work in an operating room. And so I was very interested in the fact that you used operative efficiency as a proxy for team effectiveness. Can you tell me a little bit more about that?
So our driving question, which was this relationship between operating team dynamics and surgical outcomes, is very broad. As we were starting out, we wanted to try to remove as many confounders as possible and focus on a more narrow hypothesis. And so what we did was restrict our analysis to intraoperative considerations only, not following patients longitudinally after they leave the hospital. For this reason, our main outcome variable was operative efficiency or operative duration. And the basic idea there is that if you're controlling for case complexity, then changes in operative duration represent a measure of surgical team efficiency. And this is nice because operative duration is an intuitive metric that is readily available for all cases, unlike alternative metrics that you could use for team performance that might be based on longitudinal outcomes where you have loss to follow-up. One other point is that among common surgeries, joint arthroplasties have a relatively low variance of operative duration, which makes them a very good setting for evaluating the impact of these non-medical determinants of operative efficiency like team characteristics.
I agree with Henry here. I think it was very important and maybe serendipitous that we were studying total joint arthroplasty. This really allowed us to focus in on time as one of the essential variables. You'll see we included time on multiple levels because it wasn't just about incision to closure time. It was about the other times and the ability to create efficiencies across all the portions of surgical intervention in a relatively standardized procedure. So focusing in on efficiency of the team as a metric really let us get back to the fact that this led to really team performance, team communication, and team dynamics. It turned out to be a perfect model system to study this.
And I think that what you all are discussing with the fact that time had multiple definitions really speaks to the idea that having multiple definitions of duration with room time, procedure time, and incision time was really important for your goals in this study.
I think it was actually critical. There's a common perception that, and we'll get into this more, I'm sure, that trainees increase surgery time. It has to do with when we interact with the trainees as surgeons performing a particular task that they're learning. But it turns out if you look at this data, if you look at incision to procedure to room time, they are actually engines of efficiency driving other aspects of the surgery that reduce overall room time at the same time as not having a tremendous cost at the time of surgical intervention. Again, we can talk about the confounders and maybe some of the limitations in our data related to that. But that comes out all over the data when we look across incision, procedure, and room time, which are defined as the surgical time, the total anesthesia time, and the room time. So incision to closure, intubation to extubation, and wheels in to wheels out. But only if a team member is kind of driving the efficiency and facilitating the communication of the team could they hope to reduce all of those times.
There is a lot of nuance in all of this.
Yes.
And just to add to what Dr. Amanatullah said, all of these different metrics have the capacity to capture slightly different elements of team dynamics. And this is what we're really interested in, since we're hypothesizing that many of these intraoperative inefficiencies occur due to less than optimal communication at handoffs between different staff members in the OR. And so, for instance, we found a significant negative association between anesthesia residence and procedure time, even though procedure time measurement begins at anesthesia induction. So this implies that the presence of anesthesia residence might still play a significant role in efficiency even after induction, which we thought was very interesting. In contrast, for something like circulating nurse turnover, the associations were consistent across all measures of operative duration, and in fact consistently increased with each subsequently broader definition of operative duration, which might underscore the value of their continuous engagement at all stages of the surgery.
So the finding that turnover of operating room staff during cases increased operative duration by any of your measures is really almost, I think, intuitive to any of us who have spent a significant amount of time in the operating room. What was a little less expected to me was what Dr. Amanatullah already referred to, that trainees can actually decrease procedure time and overall room time, since there's a widespread assumption that teaching residents and fellows how to operate results in teaching surgeons working more slowly. Your discussion point about trainees being involved in less complex cases certainly provides an explanation. What other potential explanations do you think we need to be considering?
We were very intrigued by this finding. As you mentioned, certainly this runs counter to some of our expectations. And it's important to note that a wide variety of factors might affect this relationship. As you mentioned, reduced case complexity is one factor that might be associated with greater resident involvement. And it's certainly true that the teaching habits of specific attending surgeons and departments could also affect this finding in a large way. That said, this finding was somewhat consistent with our pilot study, which also found a beneficial association between student presence and operative efficiency. And for me, what this ultimately highlights is that residents play a multifaceted role in the operating room. And in addition to being students, in some circumstances, they can be real assets in the surgery. And we might indeed expect and hope that there's this trade-off of inexperience versus autonomy. And as residents progress in their skills and become more familiar with the styles and practices of their colleagues, then communication errors start to become infrequent enough that the benefit of having more hands outweighs the burden of teaching.
What I noticed is that there is a bit of attributional bias, I think, that's been applied throughout this literature. So what I mean by that is because a resident might be inefficient at a particular task that we're learning in a surgical intervention, we might then imply that the entire surgery is slower and less efficient. But in reality, the resident is engaged in learning all the processes and facilitating all the processes in that surgery, and that may pay out in an overall reduction in operative time. And that particular team members, when engaged or disengaged through turnover, or we could talk about facilitating that engagement, act as engines to increase the efficiency of surgery. So while a resident might not be familiar with a particular task, say of total knee arthroplasty, like balancing, and take an additional 2 minutes or 3 minutes in order to accomplish that task with instruction, that their facilitation of tooling to the surgeon at other points by helping a scrub technician, etc., their ability to facilitate the room in expediting the transfer of the patient, vastly outweigh their learning in that one interval, which we then attribute to the rest of the surgical intervention.
One of the things that really stood out to me is that I have long held a personal bias that stable teams can be more helpful from a patient safety standpoint because of that willingness of members of a stable team with pre-existing relationships to speak up when things are a little strange. So to me, that was definitely something that was apparent. Are there additional downstream patient safety effects that stable teams or preferred staff arrangements might bring beyond improved case efficiency?
Yeah, this is a very important question, and it's worth noting that this is something that our current study didn't address. We looked specifically at intraoperative considerations, but I think that the existing evidence that we have from other studies points to yes, because the same communication lapses that drive operative inefficiency might also underlie more general inattention to detail in some cases in the operating room. And we actually cite 2 studies in our paper that show associations between team composition and post-surgical site infections, as well as hospital stay length and readmission risk. Personally, I'm very interested in extending our study methods to investigate this kind of team dynamics throughout the hospital stay. Some of the effects that we observed were only apparent when looking at the very broadest definition of operative duration that we used, which was room time. And so it'd be very interesting to expand this definition even further to consider time to discharge as well, or similar metrics, with the hypothesis that this might provide a window to look into the effects of personnel outside of the immediate operating team. And this is certainly something that we'll be looking at in the future.
I agree with Henry here. The idea of how team members facilitate other aspects of care outside of surgery, a similar model can be applied. I think there are 2 real interesting observations that can be generalized to safety, and one that relates to communication specifically on top of that. So the first one is that since turnover of team members decreased operative efficiency, it's highly likely that this is an at-risk event, and this is known for safety-related events like retained foreign objects, that the same communication breakdown across team members that makes it difficult for them to catch up, even in someone experienced, because they might not understand phase of case, room layout, or have the same communication pattern at that time, that breakdown in efficiency likely correlates with at-risk events for safety. And that as we accumulate these communication breakdowns across the team, and those can be team member changes or even a lack of a particular team member that's facilitating things, like a resident, we could get breakdowns in safety. The other observation here is that equally safe events, so well-functioning, efficient teams, it's not like we incentivize these teams to become more efficient. They were just more efficient. And they accomplished a very similar task, a knee or a total hip replacement, with, I would say, normalized complexity. That is a quality event. In a sense, these more efficient teams are generating equal or more safe surgery in a faster time. And we know that in a procedure that's about an hour and a half, each 15 minutes after that increases the risk of infection. So in a sense, catalyzing more efficient teams that perform equivalent events, and we're assuming we didn't study postoperative outcome, that is actually the genesis of quality that's occurring inside of that room in better teams. How administrators and hospitals and surgical teams catalyze that, I think, is the next step here. The final point that I will make is that ultimately, more efficient teams may also have a reduced power dynamic. This was brought up as well. And so they may be more empowered to speak up because that efficiency is not being coordinated by verbal communication. It's being coordinated a little bit off of a reflex because people know what other team members want. And that means that increased familiarity may give them more power to speak up. And the power dynamic of the room for sure is real. And unless you disable it, either with relationships or actively, we know that power dynamic can also get in the way of safety.
Was there anything that surprised you all when you started to look at your data from this study?
One thing that I found particularly interesting was the associations that we observed between operative efficiency and surgeon team member preferences. And we came into this with a strong hypothesis that there would be a positive relationship here, that surgeon preferences exist because their preferred staff members will drive operative efficiency. And we saw this in lots of cases. For instance, surgeon preferred surgical technicians and anesthesiologists were associated with operative efficiency. And in particular, we looked at a subset of cases that were performed by what we call highly preferred teams, where surgeon staff preferences were met simultaneously at multiple roles. And we found that these highly preferred teams were very associated with improved efficiency in all cases. But one big exception to this was in the case of vendor representatives. And here, surgeon preferences were actually not associated with reduced operative duration, but rather an increase in operative duration. And there are plenty of limitations to this. For instance, surgeons might be choosing their favorite vendors for more difficult cases or for implants. But in general, this implies that surgeon team preferences might not always correlate with more efficient operations. And more specifically, it could imply that some of the factors that motivate surgeon preferences in the role of vendor representative don't always correlate with operative performance.
So I agree with Henry here. Some of the unexpected observations came from the surgical preference evaluation. For me also, it was that preferences related to surgical team members like the anesthesiologist could have dramatic effects on operative time, while not necessarily even affecting the surgery itself. So that was very profound to me, especially even in incision time. The relationship with the vendor also, I think, is very complex. It does highlight, again, why that team member is there. I do think there's other complex interactions between team members that this highlights. So normally I think the vendor is trying to facilitate the scrub technician in order to facilitate the incision time of the surgical intervention, as well as probably reduce overall room time to keep the satisfaction for their product relatively high. It's interesting that they didn't change room time, and so they may be paired more often with a scrub technician that's unpreferred. So again, how these team members relate to each other, I think, turns out to be the most important thing, and that our preferences don't always get that right. I think that puts a huge burden on monitoring or evaluation or what actually happens inside of the surgical room. What I mean by that is each surgery is kind of like a test, and we call our practices practice. But if we're not having some metrics and benchmarks other than time associated with the performance of team members, we might associate things incorrectly. And I think the vendor highlights that, as well as the anesthesiologist in the preferred roles.
My closing question that I would have for you was if you have any thoughts about how your findings could become actionable for operating room leaders and operating room management.
Well, our broad hope with this study is that surgeons and administrators who are helping to put together operating teams will begin to really consider team dynamics as a potentially powerful tool to improve operative efficiency and ultimately patient outcomes, rather than just as a matter of scheduling. And more specifically, we think that surgical leaders should try to work with both surgical and non-surgical personnel to streamline communication and minimize handoffs within the operating room, and ultimately to reduce turnover wherever possible. Also, consider that under some circumstances, residents can really represent a source of extra efficiency in the operating room. And finally, surgery leaders can make attempts to arrange teams based on the mutual familiarity and preference of the team members while still recognizing the imperfect nature of these labels with respect to operative efficiency.
I agree with everything that Henry just said. I think for me, there are some dramatic realizations here. We talk about surgical time really as something that we're saving minuscule amounts, but we see differences and savings as high as 20% of the total procedure time. I mean, this is an entire case in a day across a relatively routine procedure. So for administrators, this is a revenue-generating change. The key here is that if you don't measure it, you can't manage it. If you're not actively paying attention to managing team dynamics, this doesn't auto-assemble. And it doesn't auto-assemble inside of the preferences of surgeons. It is identifying the best performing team members, and they may not all work well on the same teams. And so unless we put some effort into metrics and measuring how teams perform together and which team members perform best, we're not going to be able to accomplish that. I think that puts a huge onus on technology in this space to be able to understand how teams perform best and which teams associate with the best safety, highest quality result in the lowest amount of time. I do think it puts an onus on communication. Again, how people sign things out and how we understand what phase of the case, again, where things might be, which items are at risk to facilitate those items, and how we become formalized with what types of communication patterns work in each room. If we don't have technology backing that up, it doesn't assemble on its own. The final point, I think, again, relates to turnover. We have a constant struggle in surgery and in medicine between shift-based work and procedurally based work or encounter-based work, and that comes to bear in turnover. And so tools to facilitate turnover, make turnover less effective, or to modulate when turnover occurs are going to be super critical and are also accessible to surgical leadership and administration.
I have really appreciated our conversation today regarding your work looking at team dynamics in hip and knee arthroplasty and operative efficiency. Thank you both so much for your time.
Thank you very much.
Thanks for having us.
This is Amalia Cochran with Mr. Henry Cousins and Dr. Derek Amanatullah from Stanford University talking today about team dynamics in hip and knee arthroplasty and operative efficiency. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Audrey Foreman, Marilyn Ferkulek, Lisa Harden, Daniel Morrow, and Hannah Park. Dr. Linda Brubaker is the senior editor for JAMA Multimedia. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.